Okay.
Okay, thank you.
Thanks so much. So, just in the interest of time, I thank again to Amy and Lauren. Thank you. And let me just say, the palette is so full because our patients are so hungry and have given us all these topics that we should address. So endocrine, we've heard again and again, is foremost on the wish list. And we're very lucky to have Dr. Rose Marino, Dr. Nick Tritos here today to talk about this. So this was actually the #1 item on our patient portal list, and something that patients care about most. So no pressure.
So thank you, Dr. Eichler. So my name is Rose Marino. I'm one of the pediatric endocrinologists here at the Mass General Hospital for Children. Our topic today with Nick is endocrine issues and their management in ALD, and I think Nick will probably be talking more about AMN. So the outline or the objectives of today's talk is to very briefly review normal adrenal function, because again, we're a little short on time, and then to understand how the adrenal glands are affected, evaluated, and treated in ALD. And then very briefly, I will discuss the influences of other hormones, such as growth hormone, thyroid hormone, and testosterone, and how they can impact patients with ALD. So again, very briefly, so our circadian rhythms really help generate the circadian rhythms of cortisol secretion in our bodies, and that is through the hypothalamus, which secretes a hormone called CRH, which then causes the pituitary gland to release ACTH, which ultimately stimulates our adrenal glands to make cortisol. This happens on a daily basis during times of stress, which could be low blood sugar, low blood pressure, during surgeries, fevers. The hypothalamus secretes much more CRH in order to push the adrenal glands to make much more cortisol. So I thought this was a very nice kind of depiction of what our adrenal glands look like. They are these very small organs that sit right over our kidneys, so a lot of times you'll hear suprarenal or adrenal. They are made up of an inner layer called the medulla and an outer layer called the cortex. The medulla makes the catecholamines or adrenaline, while the adrenal cortex has also 3 distinct zones that are responsible for making cortisol, androgens such as testosterone, as well as aldosterone, which is the salt and water balance hormone. So how does the adrenal cortex, how does it do this? It basically takes cholesterol, which is the building block of all of our hormones, and depending on what pathway and what zone of the adrenal gland that cholesterol takes, either the mineralocorticoid or the aldosterone is made, cortisol or the glucocorticoids are made, or the androgens are made. So a typical person will produce in infancy somewhere between 7 and 9 milligrams per meter squared per day of cortisol. And when we talk about production of cortisol, replacement of cortisol, we talk about it in terms of body surface area. So when you see the meter squared per day, we calculate that based on an individual's height and their weight. In older children, it's somewhere between 4 and 6 milligrams per meter squared per day. And when there's times of stress, this is significantly increased to somewhere closer to 100 milligrams per meter squared per day. And talking about those circadian rhythms and the diurnal pattern, which I'll get into a little bit more, that we see in older children and adults, we remember in pediatrics that this is really not established until a baby is sleeping through the night, somewhere between maybe 3 and 6 months of age. This can also be thrown off completely in night shift workers, as well as if you're traveling into different time zones, and it can take almost 2 weeks once you sort of get back to your regular schedule to reestablishing these rhythms. So here is a picture of what our cortisol production would look like during a normal day. So plasma cortisol is on the y-axis, and then it's time over on the x-axis. So 0 is basically midnight, then 4 a.m., 8 a.m., noontime, 4 p.m., 8 p.m., and then back to midnight. And what you can see is that there is a nice rise in cortisol production in the very early morning, which then comes down. And then there are another peak sort of later in the afternoon, and overnight there's actually very little cortisol production. And it's very difficult to actually recapitulate this with our current medications of the glucocorticoids that we have. So the other part of the adrenal gland that I think that people think of as, your adrenaline and what kind of gets going, and when I've talked to patients, this is what comes to their mind when they think about their adrenals, is actually the adrenal medulla, which is not primarily affected in adrenal leukodystrophy. It's stimulated by sympathetic nerves. It's not regulated by ACTH and CRH, and its major hormone, the major substance that it makes is epinephrine, which is known as adrenaline. And this is what everyone would consider your fight or flight hormones. The issue with the way the adrenal gland is able to make adrenaline is that it actually requires cortisol from the adrenal cortex in order for it to make and release adrenaline. So that even if the adrenal leukodystrophy isn't primarily affecting the medulla, there's probably blunted response of this substance in order to help have that fight or flight response because of the intrinsic problem with the way cortisol is made in the adrenal gland in ALD. But we don't replace epinephrine. And the reason why we don't replace epinephrine is because it's known that you can survive pretty well without it. So if you take out somebody's adrenal glands for other reasons, you don't have to replace these catecholamines. They also are made in other places, such as the brain, and in the sympathetic nervous system makes the norepinephrine as well. So what are some causes of adrenal insufficiency? So basically the main cause we're talking about is a primary cause, something that is intrinsic to the adrenal cortex that's damaging it. But when we're evaluating someone for adrenal insufficiency, we're also ruling out secondary and tertiary causes, meaning is there something going on with the hypothalamus or the pituitary gland. So what we're talking about is the adrenal leukodystrophies, and why is that causing adrenal insufficiency? It's been postulated that it's affecting the actual function of the cells, or there actually can be an autoimmune response that's going on. And we know that adrenal failure can occur pretty much at any time. It can occur before, after, or at the same time as neurologic symptoms. And 10% of cases, the adrenal insufficiency is really the only thing that's seen. So what does cortisol do? Why is it so important? Well, as we were talking about earlier, it's needed to promote protein and fat breakdown. It's antagonistic to insulin. Again, it's there to help maintain normal blood sugar and normal blood pressure. And what does aldosterone do? A little bit of the same. It is actually targeted at the level of the kidney, and it causes the kidney to reabsorb sodium and to secrete potassium. So when this is deficient, what you'll end up seeing is sodium wasting in the urine, which means you'll have low sodium in the blood, a high potassium in the blood, and a high renin level. When you have acute cortisol deficiency or an adrenal crisis, what are some of the symptoms that you'll end up seeing? You'll have dehydration, very low blood pressure, low blood sugar, which is more common in younger children, and altered mental status. And this can be precipitated by illness or trauma, or really without any notable stress. What do we treat? How do we treat this? With fluids. So normal saline with glucose-containing IV fluids, and with stress-dose glucocorticoids. Again, knowing the production and what happens during stress, we'll replace anywhere between 50 to 100 milligrams per meter squared just straight off as a bolus. And then we'll follow that by somewhere in that range of a dose divided throughout a 24-hour period. Now, if intravenous access is a problem because dehydration can cause that, you can give the stress dose steroids either intramuscularly or subcutaneously. So that shouldn't be something that should wait while someone is unable to get peripheral access. If there's chronic cortisol deficiency, you could have a fasting low blood sugar. Typically, we heard some symptoms of this already earlier, where you'll be nauseous, you may be vomiting, you'll have a very poor appetite, have abdominal pain, fatigue, you can wake up with morning headaches, And then you could see hyperpigmentation of the skin, which is because of the high ACTH level. And not only will you see it in the skin, but you'll also see it in the palmar creases as well as in the gingival borders. And the way we can assess whether is this just a nice, beautiful tan at the end of the summer, or is this something a little more than that, is we say it doesn't respect tan lines. So in kids, they're usually wearing some sort of bathing suit. So we would look and make sure that if we saw a tan line, then that is not the hyperpigmentation of adrenal insufficiency. When we talk about maintenance treatment in primary adrenal insufficiency, we'll be replacing somewhere between 9 to 12 milligrams per meter squared per day of hydrocortisone. And that dose will change over time as these children grow and get bigger. If they need aldosterone replacement or the mineralocorticoid replacement, that is the Florinef. And initially in babies, they actually require much higher doses of aldosterone. So you may see a baby being on twice what an adult is on, and because there's more resistance to it in infancy. And once you're on out of that sort of resistant time frame in the neonate, then the dose actually doesn't change over childhood or adulthood. What we're balancing with these doses, though, is giving too much and giving too little. So we don't want to hear that patients are having symptoms of adrenal insufficiency, but we're also balancing that if we give too much, we're going to adversely affect their growth, cause them to have weaker bones, be gaining weight, having more insulin resistance and type 2 diabetes, and that would all indicate that they're overtreated. So a lot of times when I'm talking to my patients and their families, saying we're sort of playing a balancing game. We want to give them enough so that they feel well, but not so much that they're overtreated. And then I always ask them to get a medical alert bracelet so that if they're ever somewhere where they're not with a parent or someone knows their medical history, they'll be treated appropriately by emergency services. The symptoms of the mineralocorticoid deficiency are actually quite similar to cortisol deficiency. You can have low blood pressure, muscle weakness, fatigue, the same GI symptoms, but the difference is you'll hear the salt craving. So the kids will want pickles. They'll have the soup. They'll take the salt from the table and pour it all over their food. They can also see weight loss, and again, you'll see the low sodium and high potassium in the blood. So how do we diagnose patients when we're concerned about adrenal insufficiency? Well, in a neonate or in a very young child, they'll usually present with low blood sugar, which could actually be caused by many different things. So you may hear that a critical sample is drawn, and that could include a glucose level with a cortisol. We also look at other hormones like growth hormone as well as insulin. In an older child, we would start with just getting a morning cortisol at about 8 o'clock. If that level is less than 3, it's very suspicious. If it's greater than 15, it's highly unlikely, but most of the time we get an indeterminate value. And that's when we have to do what we call the ACTH stimulation testing, where we actually can give ACTH and watch and see what the adrenal response is. At the same time, we'll also be getting electrolytes, glucose, plasma renin activity, and we can be looking at the urine for any salt wasting in the urine as well. But the biggest question I get when I see patients in the office is, well, when do I need to stress dose my child? What constitutes a stress? Because I'll hear, well, they have a big exam the next day, or, do we have to give extra steroids for that? And the answer to those questions are pretty much no. So mild illnesses, mild viral infections, just for immunizations, if they're going just for their shots, low-grade fevers, you don't need to stress dose. If any significant fever, any vomiting, any diarrhea, or any time the child really doesn't look well to that parent, then we would always kind of err on the side of caution and give the stress dose steroids, even if it's just for a day or two, until things are figured out and they see their pediatrician and determine what's going on. So what we'd usually recommend is somewhere between 3 and 10 times the maintenance dose, or somewhere between 30 and 50 milligrams per meter squared, again, divided again throughout the day, again, usually just for a couple of days. And if they can't tolerate the oral medications or they are vomiting, then we do have our patients all have the Solucortef the Solucortef kit at home, and we teach the families how to give these injections themselves. Because again, we want to keep them safe while they're waiting for either an ambulance to arrive or until they get to the emergency room, where they may be waiting for hours before maybe they're even seen. And we want to just, again, make sure that they're covered during that time frame. A simple age-based recommendation for dosing for Solucortef is 25 milligrams for kids less than 3, 50 for age 3 to 12, and 100 for over 12. But again, this could be tailored by your endocrinologist. And again, it provides enough coverage to get you to the help you need. So there are other hormones that interact with cortisol as well, and growth hormone is actually one of them. So growth hormone inhibits an enzyme that's in the liver, and so it decreases actually the conversion of cortisone to cortisol, and the cortisol is the active hormone as opposed to the cortisone. So if there is adrenal insufficiency, and for whatever reason you're diagnosed with growth hormone deficiency, you're given back growth hormone. Growth hormone is also increases greatly during puberty. This may be a cause for needing more glucocorticoids during that time. Thyroid hormone is also an important hormone in that if you replace somebody with thyroid hormone while they're adrenally insufficient, you can precipitate an acute adrenal crisis, and that's because you're increasing the metabolism of what little cortisol is probably keeping them going. And so if you have any suspicion that there's adrenal insufficiency as well as hypothyroidism, you have to figure that out first, treat the adrenal insufficiency, and then can start on the thyroid hormone. And just the same if you're hyperthyroid for whatever reason and have adrenal insufficiency. So if you're lucky enough to have adrenal insufficiency and something like Graves' disease on top of it, you may need to increase that by double. And then very briefly, because I know this is more of an issue in the adult population, but gonadal failure or testicular failure has been seen in kids as well as in adults. The two cells that make up the testes are the Leydig cell and the Sertoli cells, and they both have been shown to be affected. So you may see a decrease in testosterone production. The LH and FSH hormones are pituitary hormones just like the ACTH, and a clue that this is possibly going on is if you measure these hormones, they may also be elevated. And hair loss is also seen in teenagers as well as I think adults. And whether this is due for two reasons is because of some of the decreased androgens, both by the gonads as well as by the adrenals. And there's also a primary effect at the hair follicle intrinsic to the ALD. Which I tried to be quick because I knew we were behind, a little behind, but I will now pass it over to Nick. But that's my contact information. If there are any questions, you can email me or call me or fax me. I'll leave it up to you. I guess we'll take questions at the end. Oh, there you go. Sorry.
I think Dean is working on the slides.
Okay, thanks so much, Rose, and thanks, Florian. Good afternoon, everyone. I'd like to thank Florian, the organizers, for this invitation. It's a pleasure to be here today and talk about endocrine aspects of ALD from an adult endocrinology standpoint. I'm an adult endocrinologist at Mass General, where I've been privileged to participate in the care of several patients with ALD the past few years. And I'd like to go over some issues that these patients have to face. I'll start by briefly outlining the case histories of two patients with ALD. Rose spoke at great length about adrenal insufficiency, but there are some points I was hoping to make and then talk a little bit about hypogonadism and then future directions. So this is one gentleman, currently 29 years old, who has ALD, actually has the AMN, and also adrenal insufficiency. And as you can see, he was hospitalized as a youngster for pneumonia, but was otherwise in good health. And during adolescence, he had a tan all year round, including winter. And as Rose said, that's really something that should really raise the suspicion for adrenal insufficiency. But at that time, nobody paid so much attention to it because he was otherwise healthy. He had some unsteady gait starting at age 21, and then at age 26, he presented with classic symptoms of adrenal insufficiency that were so nicely described by Rose, and was hospitalized. And lo and behold, he was diagnosed with not only AMN, but also adrenal insufficiency. Here's just a follow-up to Rose's presentation. His morning cortisol was 1, and this is really diagnostic of adrenal insufficiency, well below 3. ACTH, that's the pituitary hormone that normally sends the message to the adrenals to function, was sky high, and that's really indicative of lack of cortisol. And his aldosterone was undetectable. Renin was high, reflecting lack of aldosterone. So this patient is missing both cortisol and aldosterone and clearly has adrenal insufficiency. Although this was not strictly essential, he also had the ACTH stimulation test. Cosintropin stimulation is also another term for this test. In the adult world, we generally use 250 micrograms as the stimulation dose, although that's still a little controversial. And you can see he barely showed any response. His cortisol was only 1.2 at the highest point. Normally should be 18 or higher. He had a CAT scan of his adrenals that was otherwise unrevealing, showed no abnormalities. It's interestingly, there is a family history that could be relevant. He had a grandfather that had a neurologic illness, so that was undiagnosed. And his mother has AMN, but normal adrenal function, even though she does have the same genetic condition as the son. The second patient is an adult also with adult onset disease who presented with unsteady gait, some tiredness, but had no other classic symptoms of adrenal insufficiency at the time and was otherwise healthy. And he was actually diagnosed with a cerebral form of the disease, confirmed on genetic testing. But lo and behold, you can see his ACTH is actually high. And morning cortisol was indeterminate based on Rose's presentation. This falls, it's neither high nor neither sufficiently high to be reassuring, nor low enough to be diagnostic of adrenal insufficiency. But when he had the stimulation testing, he was really shown to have adrenal insufficiency. His cortisol started at 3.5, went up to 6.4. Again, below 18 is considered abnormal. And this patient had no symptoms at all at the time of his, barely any symptoms attributable to adrenal insufficiency. Pointing out again that some of these patients may have no symptoms and still have insufficient adrenal function. So it's important for everyone who has ALD to be tested because the symptoms can be subtle or non-existent. Conversely, as the first patient tells us, the adrenal insufficiency can be very subtle initially and can precede the onset of the neurologic manifestations by many years, giving a window and an opportunity to diagnose this condition earlier. So what about adrenal insufficiency? Rose showed you this nicely, so I won't go into that in any detail. But again, critically, adrenal insufficiency involves loss of cortisol almost always, often aldosterone, and androgens. That's somewhat controversial. It may be more significant in men than in women. I'm sorry, than in men, because in men testosterone is made in much larger quantities in the testes. And when the adrenal cortex is failing, for example, in some patients with ALD, as a result, the lack of cortisol releases the pituitary and the brain from this inhibition so that the pituitary produces more ACTH, which is one of the hallmarks of this condition. And that, in fact, is the molecule that causes the skin pigmentation that's so characteristic of these patients. It's actually very, very common. Up to 80% of male patients with ALD will develop adrenal insufficiency, so the vast majority of these patients. And conversely, among young adult men with adrenal insufficiency that's idiopathic, that means of unknown cause, many of these people will have ALD. In one study, 35% of these patients had ALD. So it gives us really an opportunity to detect, to diagnose ALD at an early stage. I think the message is that really all young adult men particularly need to be considered for ALD, even if they don't have any neurologic manifestations at the time. And that's something that probably pediatricians are more aware of. I think in the adult endocrine world, I don't think the message has been adequately disseminated. Now, in women, it turns out that women carriers do not suffer from adrenal insufficiency as often. In one study, it seemed to be only 1 out of 71, but still they can. So they also need to be tested and evaluated if they have symptoms. Rose talked about the presentation, the symptoms at great length, and these are all classic symptoms of adrenal insufficiency, as you so nicely described, but also in patients who are being treated, having these symptoms would suggest that they are not treated adequately. She talked about all these, so I won't belabor them. And of course, untreated adrenal insufficiency can lead to profound dehydration and decrease in blood pressure that can be life-threatening. So it's really very, very important to treat appropriately and diagnose it. We talked a little bit about the diagnosis. A morning cortisol over 18, for the most part, assures sufficient adrenal function. There are some studies and interest in measuring free cortisol because most of the cortisol is actually carried by other proteins in the bloodstream, or looking at salivary cortisol. These are all investigational. Conversely, very low cortisol levels are diagnostic of adrenal insufficiency, and in between levels are really indeterminate, and in those cases we use the cosintropin stimulation test. ACTH, again, is high in patients who have primary adrenal failure. The cosintropin stimulation test involves administration of an ACTH analog to stimulate cortisol, either in higher doses or lower doses, and there is debate in the literature which one is better. It turns out that some healthy adults may fail to respond to the low-dose cosintropin stimulation test, so in our practice we use the high dose for testing. In terms of treatment, we use both hydrocortisone, which is the same as cortisol, as the natural steroid, but also we use prednisone, which is a synthetic analog. You can see the doses that are typically used. Hydrocortisone has to be divided in 2 or 3 daily doses, with the largest one in the morning, to mimic the normal rhythm in cortisol production to the extent that's possible with the current means. Prednisone can usually be given once daily in the morning because it's long-lasting. And I think one of the things that we have learned over the past few years, and Rose showed the pediatric data, but I'll show you the adult data, are that cortisol production is much lower than originally thought. So you can see it's about 10 milligrams per day in adults. And that means that one has to be cautious because really there's no blood test that reliably tells us whether the patient is being undertreated or overtreated. We have to be cautious to avoid overtreatment that can be damaging and cause several adverse consequences, including low bone density, among others, or higher blood sugar, weight gain. Despite, I think the message I would like to make drive here is that despite seemingly appropriate replacement with glucocorticoids, either hydrocortisone or prednisone, many patients still describe feeling unwell, feeling fatigued, having poor quality of life, not feeling right. And for many decades, there was very little that was being done to try to address this issue. There is some interest in developing new forms of hydrocortisone replacement. This is a dual-release hydrocortisone preparation that has been developed in Europe, and that involves this tablet releases a part of the hydrocortisone immediately to provide a peak in the morning. And then there's a second wave of medication that's gradually released through the course of the day. So you can see that in this study, they compared the outcomes of patients who were treated with either the usual hydrocortisone dose administered 3 times a day, that's TID, or the novel dual release preparation that was given only in the morning. And you can see this is the cortisol profile, the levels of the cortisol in the blood over time. This is clock time, 8 in the morning, noon, and so forth. There is a smoother profile with a once daily preparation as opposed to the sharper peaks and troughs with a 3 times a day standard hydrocortisone. But more importantly, what they found, the investigators in this study found that the dual-release hydrocortisone was associated with a lower body weight by, this is about 1.5 pounds. I'm sorry, the opposite. So this is about 1.5 pounds. There is lower systolic and diastolic blood pressure, lower blood sugar exposure. And this was a study of 3 months over 64 adults who were treated with either form of preparation sequentially. So this preparation is currently not available in the US. It's available in some European countries. We don't know if it really improves quality of life, but it gives us an opportunity, I think, for further study, and hope that this will really help improve the quality of life of these patients. Rose talked about the need to have a medical alert and sick day rules at great length, having intramuscular hydrocortisone in cases of emergency. And then she also discussed fludrocortisone as mineralocorticoid replacement. Now, androgens, particularly DHEA, has been used, and it could be of some benefit, particularly in women with regards to quality of life and mood, and I'll be happy to discuss that if there are any questions. There's really no established benefit in men, and this is an area of some controversy in the literature. What about hypogonadism? There's a similar interrelationship between the pituitary, the hypothalamus, the pituitary, and the gonads, either testes or ovaries. You have the hypothalamus producing GnRH that drives FSH and LH, which in turn stimulate the testes or the ovaries to produce their hormones. And for the purpose of our discussion, testosterone, since we're going to focus on men with hypogonadism. So lack of testosterone can lead to also decreased sperm production, but also increase in LH and FSH by lack of inhibition from testosterone. And this is not too uncommon in men with ALD. You can see 2 different studies. In one study, 12% of men had low testosterone. LH and FSH were even more common in actually both studies, suggesting that these patients may often have at least partial deficiencies of testosterone and gonadal function. And what are the pertinent symptoms? Of course, sexual dysfunction and decreased fertility, but also it is not widely appreciated that testosterone is important for function of the entire body. So lack of testosterone can lead to low stamina, depressed mood, decreased in secondary hair, and even decreased muscle and bone, and also anemia. All of these can actually improve with appropriate replacement therapy. How we make the diagnosis in patients who are symptomatic, we measure testosterone, either total or free testosterone levels that need to be rechecked to be confirmed in patients who have abnormal results. And high LH and FSH confirm that really it's a primary testicular dysfunction that causes the low testosterone. Now, patients who are ill in the hospital should not be tested because any acute illness or injury will actually lower their testosterone, so they need to be at their usual outpatient state before they can be tested. Replacement therapies. There are many testosterone preparations. There are gels or patches that are absorbed through the skin. Testosterone can be given by an injection or can be implanted under the skin. So there are many different forms. Note that none of them are given by mouth. And that's because usually testosterone given by mouth has the potential to cause liver injury. There is also concern, especially in older men with heart disease, about the cardiovascular safety of testosterone, and that's an area of controversy. I don't think it applies to younger men, particularly those who have no heart disease, but certainly in older men who have heart disease, one has to be more cautious to target lower levels of testosterone and be more proactive with heart monitoring. And optimization of other cardiovascular risk factors. So what about our patients? Both of them have received hydrocortisone or prednisone. One of our patients is also on fludrocortisone. And the second patient I showed underwent stem cell transplant, leading to disease stabilization. So just to summarize, patients may present with adrenal insufficiency with very indolent and even insidious symptoms, and the diagnosis can be delayed. But it also provides us an opportunity for astute physicians and also sometimes patients themselves to consider the diagnosis if they're well informed. At the same time, the ALD should be considered in every man with apparently idiopathic adrenal insufficiency of unknown cause or seemingly unknown cause. Women may also have occasionally adrenal insufficiency, but doesn't appear to be as common as men. And then patients with ALD need to really have monitoring of their adrenal and testicular function because these are common issues that can impact their life. We clearly, greater awareness of this condition is very important, the endocrinopathies that are associated with ALD, and a universal screening program will likely help identify patients at risk much sooner. We talked about a little bit of dual-release hydrocortisone, but we don't really know whether its use improves quality of life. That's an area where study is needed. And actually, what about the definitive therapies, bone marrow transplant or gene therapy? Do they affect, do they prevent, do they influence the development or progression of endocrinopathies? We don't really know, and that's an area where study is needed. So I'd like to thank you for your attention. I'll end here, and both Rose and I will be happy to take questions.
Thanks, Rose. Thanks, Nick. So I guess I'll kick this off by asking what's the experience after bone marrow transplant. I know that in Krabbe disease after bone marrow transplant, there's a lot of concerns about growth hormone deficiency. Is this something that we see in ALD? And any comments on mechanism in Krabbe? I don't know if you've seen.
So, I mean, I have not seen growth hormone deficiency, but I can't say that I'm testing for it regularly in the patients that are coming in to see me. The diagnosis of growth hormone deficiency is actually kind of tricky, and the definition of deficiency is probably different depending on who you talk to. So there are different levels of cutoffs for growth hormone. And for most folks, if you're thinking about sort of a magic number of 10 to reach that for diagnosis, that's what a lot of the literature shows, is probably way too high, given that our newer assays of growth hormone can detect it much lower. And I know in the adult population, they're using 3, I think, as 3 or 4, and it's probably more like 6. So I'd actually have to look at what the data was on the Krabbe to see what they defined as growth hormone deficiency and what it sort of looked like before I was probably.
It might be an interesting comparison to do, particularly as we're now transplanting and going through gene therapy with so many boys. Joanne?
Hi. I have one question on AMN males, the adrenal insufficiency, and one for female carriers. On the males, is there a reason, a medical reason, to try to change a particular male's habit of waking up, say, at 10 or 8 one morning or 11? In other words, having varying times of when he would take his cortisol so that it was more regular and mimicked the circadian rhythm for cortisol, say taking it first at 8 regularly every day and then in the evening, rather than irregularly timed in the morning?
So the cortisol rhythm is normally entrained to the sleep-wakefulness cycle, so it really parallels the times when people wake up and sleep. So in healthy people who don't have adrenal insufficiency, cortisol really starts rising a few hours before we wake up to prepare us for the day. And that's what we're trying to mimic. I don't think with the current means we have, we cannot quite mimic that because you have to take the medication as soon as you wake up naturally with the current technologies at least. So I think obviously one would want to take it as early as possible, but to fit obviously the patient's lifestyle. Certainly avoiding taking hydrocortisone or prednisone late in the day, late in the evening. I think that's important. Sometimes I've seen patients who, for a variety of reasons, they were not informed, and they were taking their second dose of hydrocortisone, at 6 or 7 or 8 in the afternoon, and that's not going to be helpful. First of all, Rose showed you that very little cortisol is produced late in the day, and second, taking it late in the day, it can actually contribute to insomnia, problems with sleep. But again, to get back to your main question, I would just suggest taking it as soon as the patient wakes up. That's the best.
Okay, and then again, if the second dose would be when?
The second dose, if it's hydrocortisone, so the first dose would be upon awakening. The second dose would be in the early afternoon. That's typically 4 to 6 hours later. Some people have even divided the hydrocortisone into 3 doses. But again, the highest dose has to be in the morning, roughly 2/3, and then 1/3 in the afternoon. That's the typical regime.
Thank you very much. And one quick question on female carriers. It's kind of news to me about possible adrenal insufficiency for us. So you mentioned that possibly the androgens may be affected in women. What about the cortisol and the aldosterone?
Yes, of course. So all those could be potentially affected. The point I was trying to make was that androgens, adrenal androgens, are less, have not been shown to be important in men because they normally have a source of testosterone that's much more potent than outside the adrenals. But in women who don't have that, unless their ovaries are, they may have some from the ovaries, but still they have much less. So the adrenal androgen contribution is much more potentially significant compared to men. But to answer your question, absolutely, there's no question that cortisol is still the first consideration in both women and men with adrenal insufficiency.
So we should be checked for all 3?
So certainly, certainly women who have symptoms suggestive of adrenal insufficiency, such as unexplained persistent fatigue, weight loss, lack of appetite, skin pigmentation that doesn't fade,
salt
should
craving
be checked. Perhaps salt craving, should be checked. Now, as I showed you, at least from the data that are available, it doesn't seem to be anywhere near as common in women as in men. So routinely checking women for adrenal insufficiency who have no symptoms may not be always necessarily advisable. There are really no formal guidelines on this, but certainly if they have symptoms, they should by all means.
I have a question for both of you. Nick, you mentioned that there's a knowledge gap in endocrinologists related to ALD, and I think a few of our friends here have spent a lot of time going around and talking to endocrinologists, increasing awareness about the ALD. And in Bluebird Bio, we also have, we think about the projects to help narrow that gap down. If I have to ask both of you about other endocrinologists and pediatric endocrinologists, what would be the 2 or 3 best efforts or projects that can be done, or which will it, or how can we do? What can we do to decrease the knowledge gap and increase awareness about ALD in both adult and pediatric endocrinologists?
So, I think probably one of the best ways is to go to our national meetings. So there's both the Endocrine Society meeting and the Pediatric Endocrine Society meeting, which happen separately, and they have tables that can be set up that other foundations can, that are there to raise awareness. So I think that would be a great way. So if like the ULF wanted to set up a table at the Endocrine Society or the Pediatric Endocrine Society, usually in the big ballrooms, that's where everybody walks around and visits all the posters and all the tables of what's there. Other ideas?
Right, so I completely agree, and I was also going to suggest that a national meeting is the primary venue, but within that meeting there are several possibilities. One is the exhibits. As Rose suggested, there are exhibitors, and ALD Connect could potentially be an exhibitor, but also symposia can be conducted with advances in the field. as a part of the main program, or actually sometimes of the CME programs for physicians. And those are very, very effective tools in raising awareness because they're very well attended.
And there are other sessions that they have at the meetings called Meet the Professor, where they'll have experts in a field talk about a very specific topic in endocrinology. So, you know, they elicit recommendations from physicians in the society of what topics should be, you know, listed for Meet the Professor and who would be the best person to do it. So that would be one way we could help, or others could, you know, in our field, kind of at least promote it for those who are not necessarily seeing it all the time.
To tell you that I haven't seen, I haven't seen or heard anything about ALD the past at least 5 meetings of the Endocrine Society I've been to. There's really, at least in the adult world, there's been no.
We'll change that. So
It's a comment. The American Association of Endocrinologists recently published their guidelines about genetic causes of genetic causes of adrenal insufficiency. You know very well, ALD is in there, but it's not said that it is treatable. So when you don't mention it's a treatable condition, that brings it down in the priority. So I think it's 2015 guideline. Unfortunately, ALD is up there. They diagnose it, but treatment part is not there.
Okay.
I just have a quick question about pediatric stress dosing. Does it make a difference if it's done sub-Q or IM? And do you recommend or suggest antiemetics like Zofran as part of the plan?
So there's no data to say that you can do it sub-Q, but we do it sub-Q and it works just fine. Just like testosterone, when we give testosterone for replacement, we give it subcutaneously, non-intramuscularly. And in terms of, your second question was
Or antiemetics?
Oh, and, yes, they work wonderfully. So we give that routinely to children. Yeah.
Karen.
So, having attended numerous endocrine conferences in Europe to disseminate the information about ALD and Addison's disease, one big tip: don't just stand there with ALD because everyone walks past you and thinks, why are they there? You really have to grab their attention and have Addison's disease there along with ALD. Otherwise, no one's interested.
No, that's important. So we're going to learn from you in terms of pitch and messaging, and I think once we start writing abstracts, we'll have that run it past you. So I think that.
Just a quick question. You were noting that you take 2 strategies for the adult Addison's, where you use glucocorticosteroids as well as prednisone. And since you're trying to emulate the natural peaks and troughs, how do you decide which one? Because I know prednisone is slower. You'd have greater coverage. So how do you choose which one? And do you see any issues with the prednisone because you don't have the peak and the trough?
So either hydrocortisone or prednisone can be used, one or the other, not both, obviously.
Right.
The choice between them is fairly arbitrary, somewhat extent is obviously dependent on patient preference. Some people don't want to take medication more than once a day. In that case, taking prednisone may be helpful if they work and they cannot, they don't want to take medication with them and have to take it in the afternoon. And then empirically, some patients feel better with one of them as opposed to the other. So sometimes people try each of them, but there's really no scientific basis to choose between them. As I mentioned, hydrocortisone is the same as the natural cortisol, but some people may feel better with either medication for reasons that are not well understood, really.
I would say, like in pediatrics, we tend to use the hydrocortisone or the Cortef because we want them to release from the cortisol because it helps with growth better than not. So if you are on constant steroids for a longer amount of time, it does suppress growth, which is not necessarily an issue in the adult population. So we'll always usually we'll go with the twice-a-day Cortef or 3 times a day Cortef as opposed to the once-a-day prednisone because we want them to have that peak and the trough and to be released from the cortisol for the metabolic and the growth effects.
Are there cortisol-like compounds in coffee or grapefruit? Okay, because I read something online a while back, and it has to do with, I take 10 in the morning, 10 in the afternoon. I'm supposed to take 5 at night, and I usually don't take the 5 because I usually have coffee around 4 o'clock, 4:30. I don't feel the need to take it. Like usually I'll be in the afternoon and I'll be in the house and I'll just start yawning and I'll be, oh God, I gotta take my afternoon dose. So I just thought, is there any relation with coffee and cortisol and surrounding that? No?
I'm not aware of any. Okay.
Start a study on the web and report back. Okay, so we're moving. Thanks so much, Rose and Nick. This was fantastic. And let's continue some of the work together. I think that'll be a lot of fun.